This is Dr. Michael Thomas, and he's got several distinctions. One of only 4% of docs in the U.S. that have been named the best doctor for 9 consecutive years. I think that's pretty amazing. Medical degree from University of Illinois and residency at Wayne State, University of Cincinnati College of Medicine, and he's currently a professor of obstetrics and gynecology and chief of the Division of Reproductive Endocrinology and Infertility at the University of Cincinnati. Research interest in reproductive medicine, egg donation, in vitro fertilization, reproductive endocrinology. And he's going to give us an update today on contraception and specifically how to assess the best methods for patients and non-contraceptive benefits. So, Dr. Thomas, appreciate you being here.
Thank you. Thank you for inviting me. You know, I was just here actually not too long ago, spring break with our kids at the time. My son was still 16 and my daughter's 13. We were down in Rosemary Beach down the street a little ways. And so it was good to fly into, instead of Panama City, as you can imagine, Panama City, at spring break, there was more college kids down that way, so moving towards Rosemary Beach was a little bit nicer, not as many college shenanigans going on. So I remember this area well because as a newly refined golfer, after playing softball and breaking a few things here and there, I became a golfer, and so I left all my golf shorts, so I was at the Premium Outlet Mall here down the street in order to find some socks and golf paraphernalia. In half of my day, I spend doing IVF, so helping people get pregnant. In the other half of my day, I do research in contraception, so trying to help people not get pregnant. It's all hormonally related. You either turn them up or you turn them down in one way, shape, or form. And what we do, especially on the infertility side, you know, we've actually been treating a lot of patients who come in and who find each other who have things like sickle cell trait, for example. We're treating a couple now that have sickle cell trait who could potentially get pregnant on their own. And they have elected not to have a child with sickle cell disease. So they've come to us to actually look at the chromosome makeup of their embryos and only transfer the embryos that have that are either completely unaffected or that have sickle cell trait like themselves. So it's not the fact that they can't get pregnant, it's the fact that they've elected to only transfer the unaffected embryos, basically. So we do have these techniques like comprehensive chromosomal screening, or CCS, where we're using those types of technologies and doing basically either hormone array or primarily not hormone array, but gene arrays in order to determine which embryos are affected for certain diseases and which aren't. And as you can imagine, this technology is also allowing us to freeze embryos for our professional patients who decide that they aren't in a relationship now, but they want to maintain their eggs in their 20s and 30s and use them later on when they decide it's right for them in their future. But that is on that side of things, and hopefully we'll talk about that as well as some other things at our SMA conference in July 18th through 21st in Kiowa, when we talk about some of the female issues that we are undergoing, including contraception. I started out after fellowship in '90, giving a lot of talks on Norplant. Everyone may remember all the little 6 rods Norplant that went in the skin. And I think I went all around the state of Ohio and most of the region around Cincinnati giving talks on Norplant. And you know, I'd always say one of my favorite stories was in the middle of a snowy winter, committing to a talk and going up to a place called Findlay, Ohio, which is near Toledo. And got there, and there was no one in the audience. And as I was about to leave after making this 2.5-hour trek through the snow, I was about to head out, and some guy walks in, and I said, well, I was about to head out. I'm sure you don't want to hear about Norplant. I'm sure you want to go home and get home to your family. He said, yes, I'd love to hear your talk. So I gave a very abbreviated version of my Norplant talk back then, and my 45-minute talk took a total of about 15, 20 minutes as I was trying to rush through my slides. I was pressing a button and it almost looked like cartoons up on the slide deck. And after my talk, I asked him if there were any questions, and he said no, and I said thank you, and I was about to leave, and he said, where are you going? I'm the second speaker. So, so I've learned to make sure that I always take enough time to give my talks just in case the second speaker is in wait. My disclosures are pretty straightforward besides the ones that are listed. We do a lot of contraceptive research, and I've had an NIH grant continuously in contraception since 1995, and we just renewed it another year ago for another 7 years, looking at different types of contraceptive agents. So my talk is not only from the perspective of someone who has been around contraception, but someone who's also obviously brought a number of things to market, even in phase 1 and phase 2 trials, which is what we do a lot of. And also, I wanted to spend more, when I talk about future of contraception, not only talk about things that are in the female contraceptive market, but very little time do we ever talk about what's on the male side. That's always a big question. What's new in male contraception? So toward the end, we're going to spend some time talking about that as well. So at the end of this talk, a participant should be able to differentiate between the progestin components of a birth control pill, which is always the big questions that we had before I came in here. We're talking about being a board examiner. I've been a board examiner on the American Board of OBGYN since, REI board examiner since 2000. And now, just this past July, I've become a board member on the American Board of OBGYN. And one of the questions I always ask is about the different types of progestins in the birth control pill. So I consider this a very important topic. Also, hopefully, by the end of this talk, you'll be able to understand a lot of the non-contraceptive benefits of the hormonal agents, as well as understanding the future of male and female birth control options. I went to Northwestern for college, and I was actually a radio, TV, film major, so I spent some time in the television market in Chicago, and it was also sort of pre-med at the same time. And, well, I guess not sort of, I went to medical school, so I guess I was a pre-med at the same time. And so one of the things that I always emphasize is trying to, in our residents especially, and my partners, just try to emphasize the fact that, you always want to present things in the best possible light. And in contraception, sometimes the different types of contraception agents out there sometimes get a bad rap, but for the most part, they're obviously very safe and very effective. Sometimes they don't come across that way, but very few problems come from the modern contraceptive agents that are out there. Contraceptives have been around for a while. The most commonly one used is, of course, the birth control pill. The birth control pill has first entered the market in the early 60s. And the amount of birth control, the amount of estrogen, ethinyl, estradiol, mestranol in the birth control pill and the Enovit pills, I'm sure some of you may remember those, was basically the equivalent of what we have now is about 150 of ethinyl, estradiol, or mestranol, and now we have pills that are as low as 10 micrograms of ethinyl, estradiol. The amount of the percentage of patients who use a pill decrease over time, and the percentage of people who use nothing, depending on the age group, stays about the same. Sterilization does increase over time. Both male and female sterilization increase and become the predominant method of contraceptive use. But the primary thing that we've been more and more concerned about is those of us who continue to prescribe birth control pills to women and or men of all ages. The most common times that couples have, or women in general have unintended pregnancy is under the age of 20, and the second most common time is over the age of 40. Even though I see a lot of patients over the age of 40 who are trying to get pregnant, most women over the age of 40 aren't, and still need to use a method of contraception, and we still need to counsel them about a method of contraception. OCs came out in the early 60s. The introduction of the low-dose pills started in about 1974. The formulations that were greater than 50 micrograms of ethinyl estradiol and mestranol actually were withdrawn from the market in 1989. It wasn't that long ago. The introduction of the OCs that were less androgenic with the norgestimate and desogestrel came out in the 1990s, and then the most common introduction of a newer pill, which is more of instead of a 19-nor testosterone agent, the 17 carbon compounds, drospirenone, came out in 2001. And the newer progestins that will be coming out are more of the either 19-nor agents, 19-nor testosterone agents, or 21 carbon progestins that will be coming out in the next couple of years. So with birth control pills, it's the most common reversible method of female use contraception in the United States. And it has a very good rate for both the typical users and the perfect users. The perfect users being the people who take the pill every day. They take them about the same time every day, versus the typical users, which are patients who occasionally miss a pill or who don't take them the right way, or who don't take them when the next pack is due. And that's really the most common reason that people tend to have an increase in pregnancy in the oral contraceptive users. There are very rare, serious side effects associated with the oral contraceptive, especially the combination oral contraceptive. Very few patients have DVTs or PEs, and there are very few persistent intolerable side effects or absolute contraindications, and mostly they do have a lot of non-contraceptive benefits. More than about 18 million women use the pill currently, and they make up about 30% of the current contraceptive users right now. And about 80% of women overall have used a oral contraceptive at some point during her reproductive years. The biggest problem, though, is that there's a high discontinuation rate with oral use. Because of that, a lot of teens, a lot of young women who may have some irregular bleeding, who may have nausea as a side effect, will stop the pill and either use nothing or preferably drift to an over-the-counter method or try to use another type of method. Among the women who use an oral contraceptive, the average use is only about 5 years. You would think longer, but the average use is only about 5 years. So some of the common side effects, especially in the teenagers and young adults that will cause them to discontinue use of the pill, include the irregular bleeding, the nausea because of the estrogen in the pill, some weight gain. Some women even complain of weight loss associated with the pill, and they'll stop the pill because of that. Because of the different types of progestins, some progestins may be more amenable to them than others. They can have mood changes, headaches, and breast tenderness associated with either the estrogen or the progestin component. And to me, this is, in my mind, one of the most important slides, because this tells you the different types of progestins, because the estrogens is either a mestranol pill, which is only in the 50 microgram pills these days, or the other pills. So 90% of the pills we use these days is an ethinyl estradiol pill. So that doesn't really change from pill to pill, but what makes one pill different from the other is really the progestin. And the progestins are sort of divided up into these 3 categories. A progesterone-like agent, or 21-carbon pregnane. Progesterone is generally 21 carbons. An androgen is generally a 19-carbon compound, steroid compound, and a estrogen is an 18-carbon compound. So the pregnanes, which are more progesterone-like, all of these have an affinity to the progesterone receptors. The 19-nor testosterone agents have an affinity both the androgen and the progesterone receptor. And then the 17-carbon compounds have an affinity to the progesterone receptor but have no androgenic component whatsoever. So it's really its effect on the progesterone receptor. So anything that is not a natural progesterone is a progestin, and these are all the progestins listed, like medroxyprogesterone acetate, cyproterone acetate, which isn't used in this country, or chlormadione acetate, which isn't used in this country. So the most commonly prescribed pregnane is medroxyprogesterone acetate, which used to be in a birth control pill formulation, but is not anymore. And there are newer 21-carbon pregnanes that are coming on the market within the next couple of years, but are still being tested now in either ring or pill forms. The 19 nortestosterone agents, which are divided up into the estranes and the gonanes, with the estranes being norethindrone acetate, and ethinyl diacetate, and the gonanes being generally thought to be more gonadal, are the norgestrel and the levonorgestrel, but then the earlier, the third degree or pregnanes gonanes are the norgestimate, desogestrel, and gestidine, and then the non-androgenic progestins is the progesterone, which has been on the market now, as I said, since 2000. The biggest non-contraceptive benefit for oral contraceptives is the fact that they decrease the risk of certain cancers. One of the biggest is ovarian cancer. OCs, combination OCs, or any OCs that just stops that monthly popping of the serosal surface of the ovary decreases the risk of ovarian cancers up to 40 to 80%. Endometrial cancers, 50 to 60% of the patients, because you have a constant stimulation of a progesterone, either 21 or 24 or continuously on the endometrial lining. That helps to decrease the risk of endometrial cancer. Also, there appears to be a decrease in the risk of colorectal cancers by 18 to 40%. No increase in breast cancer in OC users and even former OC users because of their use of birth control pills, and former OC users who are currently 35 or 65 years of age. The risk of cervical cancer does increase, primarily dealing with the exposure to potentially men who may have some HPV. So the risk of cervical cancer only increases in long-term OC use in women infected with the HPV virus. But the birth control pills in and of themselves do not increase the risk. Also, a decrease in the risk of salpingitis because of the thickening of the cervical mucus, not allowing infected sperm inside the uterus. Because the lining of the uterus is decreased, there's less anemia associated with the use of users of OCs versus non-OCs. And also there's less benign breast disease associated with the use of OCs. Some of the symptoms of PCOS that patients may have, particularly the hyperandrogenic midline increase in hair symptoms of PCOS, are noted to decrease because you increase hormone sex hormone binding globulin, excuse me, therefore binding more of the hormones, and you also decrease LH production by the pituitary gland. You then did a decrease in some of the hyperandrogenic symptoms when you use OCs. There's less functional cyst formation, less benign ovarian neoplasm, fewer long-term uterine fibroids, and also a decrease in rheumatoid arthritis noted. As far as intrauterine contraception, particularly the IUD, both the copper IUD and the Levonorgestrel IUD, use in the United States is not as high, and I don't, unfortunately my countries were cut off on this slide, but contraceptive use in the United States is low for intrauterine devices in women 15 to 49, but it is higher in other countries, and unfortunately it doesn't tell me where those countries are. The Delcon shield was introduced in 1970s, but these cells were halted when there was thought to be an associated increase in intrauterine infections. associated with the Delcon chill. The Delcon chill was then halted off the market. Because of that, there was this backlash with intrauterine contraceptive devices. Manufacturer of the copper T, copper 7 at the time was removed. Lippy's Loop was also voluntarily halted at that time. The copper T then came back in the mid-'80s, and the Paragard was approved for use at that time. And there are a number of new copper IUDs that are going to be on the market probably within the next 4 to 5 years to sort of compete for that market for the patients who are also using not only the Paragard, but also the Mirena and the new generic Levonorgestrel IUD, Liletta, which was approved this past year. But prior to the Levonorgestrel IUD that was Mirena that came out in 2000, there was a Progestisert, which was a 1-year natural progesterone IUD, but that was removed from the market because obviously using a 5-year IUD that had a progestin in it was probably much better than using a 1-year Progestisert IUD. And then the Liletta, which was actually spearheaded through the Buffett Foundation and this company called Medicine 360, was approved and has been on the market since this year. And the whole goal is to bring to market a new lower cost IUD to compete with Mirena. But the nice thing about both the Mirena or the Liletta IUD, both are Levonorgestrel containing IUDs. Both have this reservoir area that contains Levonorgestrel, with the Mirena releasing about 20 micrograms of Levonorgestrel, and the newer, smaller IUD Levonorgestrel releasing about, I think, 12 to 15 micrograms per day. The Mirena is good for 5 years, approved in the United States. It is approved in some other countries for 7 years. Currently, the Liletta or the generic IUD is approved for currently 3 years, but the goal is to get an approval for 7 years. In our group of investigative studies, we have patients who are now using the generic Mirena IUD now 6 years out, and the goal is to get them out to 7 years, if at all possible, with, of course, no decrease in effect. IUDs work primarily by, believe it or not, thickening cervical mucus. That's its primary mode of action. It sits inside the uterus, obviously, and acts as a barrier, but its primary mode of action is thickening cervical mucus. And it does affect sperm motility and inhibits sperm function. It also has an effect to suppress, obviously, a direct effect of the Levonorgestrel to suppress the endometrium. And in some cases, it has an effect to inhibit ovulation, compared to, say, a copper IUD, which, of course, causes a pseudo-inflammatory effect inside the uterus and also acts to prevent sperm from entering the tubes. This Levonorgestrel IUD has a number of other positive non-contraceptive benefits on both the previously manufactured Levonorgestrel IUD and the current manufactured IUD, the newer Levonorgestrel IUD. One of the non-contraceptive, some of the non-contraceptive benefits include decreasing bleeding, but when you compare Levonorgestrel for its efficacy over 5 years to even sterilization, you can see that with the Levonorgestrel IUD, you can see that the rate over 5 years, cumulative failure rate is about 0.5%. The copper IUD failure rate is about 1.4, and all sterilization is 1.3, and all female sterilization is 1.3, and postpartum sterilization is a little bit lower at 0.6. So basically, the levonorgestrel IUD compares favorably to sterilization in general. And as a long-acting reversible contraceptive method, these patients can get pregnant again if they do so desire. Even though we see a number of patients who come in to get pregnant again after tubal ligation, this method of contraception can also be easier used just by obviously removing, getting them pregnant again, and then putting another one in without necessarily having to do a tubal reversal or the cost of a tubal reversal. Return to fertility is very high with both the copper IUD and the levonorgestrel IUD. So removing the IUD, fertility returns very quickly with both. So no long-term effect of having the IUD inside, no long-term effect with scarring of the uterus with either IUD. So nothing that we tend to necessarily need to be concerned about. Some of the potential complications, of course, is or contraindications, I should say, is just making sure that before they put the IUD in that they're not pregnant. Also, just making sure that there's no evidence of, no history of cervical infections, no necessarily any need to do a screening at the time of insertion unless the patient is at high risk for any type of problems or if there's a suspicion of any type of cervical issue. And making sure also that there is no evidence, outward evidence of a uterine anomaly. And most of these IUDs can be placed in any size uterus without any decrease in failure. Expulsions can be common. Some of the potential complications of IUD placement is always the possibility of expulsions, and this is with not only the levonorgestrel IUD, but with also the copper IUD. This tends to occur more so in patients in a postpartum state than any other time, but any expulsion is generally going to take place in the first 6 months after the IUD is placed. And the overall expulsion rate over 5 years is only about 4.9 per 100 women. Perforations, believe it or not, are very low. It all has to do with a lot of it has to do with the training of the person that put it in the IUD, but believe it or not, these perforations are very rare. With one of the new IUDs that we're testing now, I always say some of these IUDs almost put themselves in. You don't really have to do a lot. These inserters, both common inserters like the Paragard, even the Mirena or the Letta inserter, they're very easy to use, and it's just a matter of just following the appropriate way of putting them in, which is basically to measure the cavity of the uterus, place the IUD in to a small degree, open up the arms, and then place the IUD toward the top of the fundus. And always measure ahead of time, and they always have the devices on the IUD to make sure you don't go past the fundus to perforate. But like I said, in the non-pregnant state, it's much easier than in the pregnant state, but in most of the studies that have looked at even postpartum insertion, the perforation rate was as close to zero as you could get. Some of the possible side effects with the levonorgestrel IUD are the hormonal side effects, which are the mood changes, because there is some of the levonorgestrel that gets into the bloodstream in the first year. Levonorgestrel, because it's a gonane, is one of the more androgenic progestins, so acne in some women, particularly probably more like the PCO type patient who's very sensitive to some of these more androgenic hormones can sometimes be noted. Some mood changes, but this is very rare. Headaches on occasion, breast tenderness and nausea, but and more importantly for some patients, levonorgestrel IUD or any of the copper IUDs are not associated with any weight gain. So some of the non-contraceptive benefits because of a levonorgestrel IUD, say compared to a copper IUD. With a copper IUD, you do get a slight increase in cramping and a slight increase in blood flow, but with the Levonorgestrel IUD, some of the non-contraceptive benefits, for example, patients who may have adenomyosis or even fibroids that aren't inside the cavity of the uterus. So if they don't have submucous fibroids, the IUD can be used for, Levonorgestrel IUD can be used for menorrhagia. Therefore, it increases hemoglobin levels and iron stores in these patients who tend to have heavier bleeding. It reduces dysmenorrhea because it does have an effect to decrease the prostaglandin production and the prostaglandin effect in the uterus. It is also a good therapeutic option because of the decrease in dysmenorrhea in our patients who have endometriosis and, as I said, who have adenomyosis and either intramural or subserosal fibroids. There is a long-term endometrial protection, even in patients who are using, say, hormone therapy, who don't tolerate the progestins as well, in your menopausal patients or your perimenopausal patients who are on hormonal therapy, who you don't necessarily need higher dose hormones like a birth control pill, who may want to use your Premarin or estrase, but you can use, because they have to have a uterus, and they have to have some uterine protection with a progestin instead of using Provera or norethindrone acetate, placing either a Skyla, smaller Levonorgestrel IUD, or the common Mirena or Liletta IUD inside the uterus, and using estrogen without any hamperance or decreasing the protection inside the uterus. Also, there have been a number of studies to show that it mitigates tamoxifen-induced hyperplasia or polyp formation in the uterus. So in patients who take tamoxifen as a post-breast cancer therapy treatment, and they do have this increase in hyperplasia because of the effect of tamoxifen in increasing the endometrial effect, increasing proliferation of the uterus, and therefore also increasing endometrial polyp formation. If a Levonorgestrel IUD is placed, these patients have 0% risk or development of endometrial hyperplasia or endometrial cancer. They also have 0% development of endometrial polyp formation. So it is an emerging benefit for women with breast cancer who are on breast cancer treatments that may increase their risk. Also, the low levels of Levonorgestrel on breast cancer recurrence or development, however, is not known, but is not thought to hamper that in any way, shape, or form. As far as the bleeding is concerned, it does compare to patients who are, say, in Levonorgestrel IUD users. Before treatment, you can see that the amount of menstrual blood loss is high, would mean of about 150 milliliters of loss, but over time, this loss is decreased over 12 months with the use of a Levonorgestrel IUD. Other methods, other reversible methods include, that can be used include vaginal ring, contraceptive patch, diaphragm, which isn't really used that much anymore. I was talking to residents about a diaphragm and fitting a diaphragm the other day. It took us a while to even find a diaphragm fitter in our clinic. That's almost non-existent these days. Most patients aren't even requesting them anymore. Condoms, which we'll talk about in a second, cervical caps, and some of the subdermals, the Implanon and the Explanon, are available. Obviously, Norplant is off the market after a lot of fanfare many moons ago, and then it was all of a sudden vanished. Condoms are still the most widely used method. It's been around for over 400 years. It's really the only marketable male contraceptive right now. About 440 million condoms purchased each year in the United States, 54% by women. So the market is really, when you look at a condom ad, it's really directed at the female patient versus the male patient, because most men aren't buying them. It's really the woman who's buying them to protect herself. The use rates are obviously higher in the younger patient because they're easier to get over the counter. Whereas as women get into their 20s, they tend to drift more to birth control pills, but still, a number are still using a combination of birth control pills and condoms for protection against sexually transmitted disease. Two types of condoms that are available: the latex condom, which is obviously a natural rubber, but there are some issues related to allergy concerns. There are some of these condoms that have either lubricants or non-lubricants. The contraceptive lubricant or the spermicide lubricant are primarily for marketing purposes. There's not enough spermicide on a spermicide-laden condom to really do anything to protect in case there was a breakage or spillage of a condom. There are also the natural skin condoms, which a lot of them are made from lamb cecum. They have small pores in them, so they aren't really 100% protection against an STD or something like an HIV. So the latex condoms do protect. Also, the non-latex condoms, besides the natural skin, are also the polyurethane condoms or even the nitrile type condoms. They do have a protection against STDs, and they don't appear to have the same allergy concerns. 100%, there are 100 different brands out there. They're the kinds with and without reservoir tips. There are the rib condoms and the smooth condoms. There are the color condoms. There's transparent condoms. There are flavored condoms. There are vibrating condoms. So the condom market, they're just trying to come up with new and different types of things in order to bring people, particularly women, to the market. There is a female condom on the market. I was actually on an FDA panel to approve the second female condom. It is it's a larger condom and has a inner part that goes over the cervix and the outer part that sticks outside of the vagina. Unfortunately, it doesn't have arrows so that the penis goes into the right place. So sometimes there is some areas that get around the condom. The condoms are good size condoms. You can put a can of Coke and a few pieces of ice in one of these condoms. So it could be used as a storage area as well. They are, as you know, have the same protective and failure rates as the male condom. In the perfect user, which means that you stand still, you don't move a lot, you get a 2% failure rate. But for those people who are a little bit more active or who aren't using it every time, the typical rate generally goes down to anywhere from 15 to 18%. And the most common difference, though, between the typical and perfect user is just consistent use. So if you forget to use the condom, or if after one act of intercourse you forget that the condom, it didn't come off, it's stuck inside, unfortunately, if you get pregnant, that's still a failure rate of the condom. So ways to decrease failures is to use throughout the act of intercourse. Some men, believe it or not, take them off after or during the process of intercourse. There is breakage, and there's a lot of literature on breakage and slippage. Breakage obviously being a tear in the condom, slippage obviously meaning it just slips off and it's either remains intravaginally or is on the side of the bed or on the headboard. There is either poor withdrawal of the condom that can take place, incorrect placement on the penis. We once tried to develop a condom called the Easy On condom, thinking that that would be the perfect condom. You can put it on either way. You didn't have to roll it one way or the other. You could roll it either way, and it never really made it to market. There's also improper lubrication. You obviously don't want to use oil-based lubes, which increase the potential for failure of the condom. And obviously, I've even heard people using double condoms, either putting on 2 condoms in case the other condom breaks, or using both a male and a female condom, but then why do anything? The Implanon or Explanon is also available now that the Norplants have been off the market, which is the one implant. The Implanon the Explanon, excuse me, is basically the same thing, only you can sort of see it on ultrasound. Basically it has a Levonorgestrel, which is a derivative of desogestrel. It has a controlled rate membrane. These are good for 3 years under the skin. They're very high as far as efficacy is concerned. No pregnancies reported in a number of the clinical trials that have been done. In one study, however, there were 218 pregnancies, and when they analyzed these pregnancies out of 240,000 women, 84 were due to non-insertion, meaning it didn't really get inserted, but it was counted as a failure. 19 were due to incorrect timing of the cycle, meaning that the Implanon was placed in the luteal phase instead of the early follicular phase. 46 had pregnancies prior to, had 46 prior conceptions, meaning that they were already pregnant prior to it being put in, or in only 13 out of 240 were thought to be due to method failures. So when it came out in the United States, there were a number of rigorous training programs, and they didn't want to repeat the Norplant issues. With Norplant, even though a number of us went down to the Dominican Republic, I think I was down there for 2 weeks training with Norplant, learned how to put them in, and came back and gave classes in how to put in these 6-rod Norplant rods back in the early 90s. Actually, it was the summer of 1990. And when we came back, they were selling the Norplants to anyone who wanted them. You didn't have to go to a training program. So there were a number of people who were putting in the Norplant rods who were putting in incorrectly. And there were a number of rods that were in the muscle. There were a number of rods we were finding later that were in different places in the arm. And then when they were removing them, some folks were removing them if they weren't trained. They were severing the tendons, severing vessels. So there were a number of issues with the Norplant. So the Implanon, Explanon people decided that they only wanted people who truly were trained, and they have not had a lot of sales in the market, but it seems to be actually increasing in the residency programs and in some of the hospitals that see a number of Medicaid patients because they can be placed. They've encouraged them to place them in a postpartum state, and those patients tend to do very well and seem to be very accepting of the Explanon. Rapid return to fertility with these rods. So once they're removed, fertility comes back very quickly, and generally no problems with them. Female contraception, which is just the cutting of the fallopian tubes, either mechanically or directly cutting them. Failure rate is obviously very low, and the only time you really get an increase in failure is due to very few recanalize. It's just sometimes it's operator error where they may actually pick up the round ligament instead of the tube because you haven't defined the tube out all the way out to its fimbriated end. There are a number of different types of female sterilizations that are available, both interval or postpartum, and most of these techniques are associated with decrease in future pregnancy. Failures may be due to pregnancy at the time of the procedure. Very rarely, though, fistula formation, mostly medical error, or sometimes equipment failure, meaning that you think you're cauterizing the tube, but the equipment isn't really doing what it's supposed to do. So it's very important to make sure that that you have proper equipment, and the equipment that you use for cauterization is checked on a regular basis. And the cost for female fertilization is about $1,200 to $1,500. There is a risk of ectopic pregnancy after female sterilization, but 32% of pregnancies that occur after female sterilization, is thought to be due to ectopic pregnancies. So anytime you have a patient with a pregnancy after a female sterilization, you need to think ectopic pregnancy first. The lowest incident is with the unipolar coagulation and postpartum salpingectomy. Its causes include fistula, inadequate coagulation, or inadequate occlusion. There is the transcervical techniques, Essure, and we use a lot of Essure even in the fertility market because you can put an Essure in a patient who has a hydrosalpinx, and you can push the Essure further up in the tube, and that will decrease the risk of that fluid from the hydrosalpinx entering the tube. And the Essure obviously can be used for sterilization. There have been some reports in the literature, most recently with patients who may have nickel allergies or some type of metal allergies. And we have seen patients in the past who wanted to get pregnant after Essure. And a lot of these patients can, particularly if the Essure is placed higher up in the tube. Jack Lippies and I and a guy by the name of Elton Kessel have been trying to get funding for quinacrine trials. Quinacrine, of course, is an anti-malarial drug, but when placed inside the uterus near the tubes, it will actually sclerose the tubes. It's not been used. It's an irreversible method. It's really not caught on, not gotten a lot of traction. We've gotten some monies and done some trials, but very few continued trials. And I know for Jack Lippies, this is probably one of the last things he wants to do since his IUD isn't being used anymore. The silastic plugs have basically been taken off the market for female sterilization. They didn't really catch on very well. And this is sort of a picture of the Essure going inside the tube, occluding the tube, and then most of these patients then get a HSG at some point to make sure the tubes are occluded later on. So vasectomy is still the most, besides condoms, the vasectomy is also the other method of male contraception at this time, where you block the vas deferens. The failure rate is actually very low, and the cost for vasectomy is very low. Studies do show that a high failure rate primarily occurs if there's still ejaculate, sperm in the ejaculate. So you have to wait at least 3 to 4 months after sterilization. We do not have laser vasectomy yet, but I'm sure it's around the corner. With the vasectomy, all you want to do is palpate, and these vasectomies are done in clinics all over the world. Palpate the vas deferens, inject lidocaine, just make a small incision, take out the vas, cut it, and then either cauterize or sew that area, and then just place a few stitches at the scrotum on both sides, and that's it. You do have some complaints post-operatively, some swelling, bruising, some discomfort, and occasionally bleeding from the incision site. And sometimes men can have a dragging sensation or tenderness in the scrotal area. Very rarely do you get this chronic testicular pain syndrome, where 33% can have testicular discomfort, 2% can have pain that actually can negatively impact their life of those who get the chronic testicular pain. And some of the treatments include sitz baths, NSAIDs. Some men either have to undergo sperm cord blocks. Some of the major issues is actually you may have to do actually a vasectomy reversible or even denervation of the spermatic cords. Failures are due to not waiting the 3 to 4 months, or recanalization of the vas is very rare, though. The occlusion of the wrong structure can sometimes occur, and sometimes there can be a congenital duplication of the vas. But compared to female sterilization, the cost is almost a third to a fourth of female sterilization. So on the future horizon of the reversible male market, there is really, like I said, nothing new since condoms came out about 400 years ago. And to be honest with you, most men, the majority of men, aren't really active in the family planning aspects of what happens in their household. Worldwide, reversible male methods are only used by 10% of men, and in more developed countries, even the United States, it's only used 25 to 30% of men may use a condom at some point. And the failure rate, as we said before, is 15 to 18% with condoms. The whole goal of a male method, particularly a hormonal method, is to try to decrease sperm counts. So when we look at the future of male contraception, you want to get to a point where sperm counts are either completely gone, but a lot of studies have been sort of inconsistent when it comes to hormonal methods to get the sperm counts completely down to 0. So the goal is to get into this sort of severe oligomenorrheic sweet spot of about 1 to 3 million sperm per milliliter. And if you can get there, the failure rates of a hormonal method are equivalent to what you see in a female method, which is less than 1%. So some of the non-hormonal methods that have been used in experiments include external heat, sort of heating the testicles, but that long-term, that can be a little difficult. Hot potato, that's all I keep thinking of when I think of external heat for male methods of contraception. And nifedipine has been used in experiments, enzyme inhibitors. Immunocontraceptives have shown some inconsistent use as a non-hormonal method. And the other thing with immunocontraceptives is that sometimes they may not be reversible. Retinoic acid receptor antagonists, papaya seed extracts, oleanic acid and neem leaf extracts have been written about in the literature. Vast occlusion methods, where even a reversible vast occlusion method, where you have a reversible inhibition of sperm under guidance or removal of an injectable silicone plug. The vast gel is one method where you actually can put in a gel inside the vas deferens and then potentially inject fluid to remove it, or where you put in this stuff and then actually inject it out at some point whenever you want to remove it. And also there's kind of the equivalent of an IUD in the vas, where you place these intravas devices and they can be placed inside the vas deferens and they can be later removed. So these type of experimental devices are being used not in the United States right now, but they're being used in other countries and somewhat successfully. The hormonal methods are probably the ones that have the most promise on the horizon. There are different pills, there's injections, there's implants, and there's creams. People have used testosterone alone, either testosterone enanthate, undecantonate, buciclate, or this 19-NT. Also, different types of experimental methods have been used with progestins, and then giving testosterone add-back. So using a progestin to lower sperm count and then giving testosterone, lowering testosterone, and then giving back low doses of testosterone for function. The biggest problem is you can give a large dose of progestins, but then that decreases testosterone, but not only does it decrease sperm count, it decreases the ability to perform. So by giving the levonorgestrel or desogestrel, or they even use Depo-Provera in some men and some of the other progestins, and then giving just small amounts of testosterone to maintain performance. Also, GnRH antagonists have been used along with testosterone add-back in patients. And the lower line is severe oligospermia. The upper color is azospermia. You can see with this 19 nortestosterone agent, you sort of get a good efficacy, but some of it is related to oligospermia, some of it is related to azospermia. With testosterone enanthate and testosterone buciclate, you could get a lot of severe azospermia and really no, this is severe oligospermia with no azospermia. And this is testosterone enanthate is sort of a combination of both. Mint, which is a different type of testosterone agent, actually does more severe oligospermia. And we'll talk about some of these individually. So on the horizon, there is this combination of nortestosterone, a combination of nesterone and testosterone gel. So you get a gel of both a progestin gel and a testosterone gel. The nesterone has no androgenic or estrogenic properties. It's a 21 carbon compound. 89% of the men who use this combination of both the progestin and the testosterone will have a sperm count less than 1 million. The DMAU, or the dimethyltronone undecantate cannonate, is a 19 norandrogen agent that has both androgen and progesterone receptor activity. But this MINT, which is actually a 7-alpha methyl 19 nortestosterone, it's actually more potent than testosterone, can be used alone, but with some of the testosterone agents, you actually get an increase in benign prostatic hypertrophy and some slight increase in, potential increase in prostate cancer. But with MINT, you get none of that. It does not have any effect within the prostate. It seems to support bone health. It reduces the intraprostate androgen activity. But one of the issues with experimental, some of the studies that have come out, when they use it as an implant, it's primarily used as an implant, and they use it with a progestin sometimes. The release rates with the progestin don't seem to work very well. One of the biggest challenges to male contraceptive research is that a lot of the pharma and biotechs have sort of abandoned this area. There's some limited governmental funding that's out there. The NIH has 10 sites that are looking at contraceptive development. They're looking at both basic, translational, and clinical studies, and a lot of them primarily concentrate on mechanisms that regulate sperm maturation, and they also identify new therapeutic targets for male agents. This is a device that can be theorized to work later on for male contraception. I saw this a couple of weeks ago at the ASRM meeting. This is actually a device that was being used to collect sperm for men who have trouble collecting sperm, to get a sperm specimen. But we figure you just place your male member in there, just drain all the sperm out, and then that can potentially be used not only as a fertility device, but also as a contraceptive method, and I have named it Drano. The biggest problem is probably good for men under the age of 30, because after 35, once this sperm is drained, you just want to go to bed, and that's it anyway. So I've been lucky to be part of a group, NIH group contraceptive trial since 1995. We were one of the original groups, and so I'm 100% for writing NIH grants. There were initially 9 centers, but there are now 19 female centers. But still, the original 9 are the ones who actually get most of the grants. We've helped to bring to market some emergency contraceptive agents, as well as different types of gels, including buffer gel, which is a gel that lowers the acidity of the vagina to actually inactivate sperm. The Easy-On condom, we talked about different types of rings. We're currently about to use and work on a Depo-Levonorgestrel agent to compete with Depo-Provera. So the take-home message is that all female contraceptive agents, hormonal agents, are somewhat of a variation of the OCs. It's either a pill or a ring or a patch, but they're all basically a variation of an OC. There are no new reversible male contraceptive agents that are on the market currently for 400 years, and there's not a lot of money looking at male contraceptive agents right now, but the question always is, with all the female contraceptive methods out there, should we even put money into male contraception? But there are some monies going into it, but not from external sources primarily, just some governmental monies. With that, I'd like to open it up for questions.
Let's give Dr. Thomas a hand. That's an incredible overview. I know most of us, are not either on either side of that, but that's really good. I appreciate your work. That's hot potatoes, huh?
Yeah, exactly.
Okay, we have a few minutes before the break. Let's take some questions in the back.
I got one. The Mirena contraceptive also has the Manorage FDA indication, which has been important for some of us who work in religiously funded healthcare settings where we couldn't place contraceptive ones. Does the Liletta have
I do believe it does. I don't know. I would assume it should be like for like, but I would assume it does.
So that's why I don't know if
I'm sorry?
the Skyla,
Right.
the one from the same company, doesn't have it.
But I'm almost sure Liletta does, but I don't know for sure.
So that's Liletta and Marina is the other?
Morena.
Marina?
Yep.
Okay.
Like I said, Liletta is the newer one, in that it was primarily developed, obviously, not only to compete, but also to be used for the patients who couldn't afford the Mirena, and particularly in the healthcare, the clinic healthcare area, where you see a lot of your self-pay or Medicaid type patients.
I'm going to ask you a quick one. It's with population health care kind of being on the horizon with all the changes in this new milieu, what do you see in terms of birth control alternatives?
Well, I mean, a lot of these contraceptive methods obviously are being covered, which is a good thing. So it's hard for us actually to recruit patients for studies because of that. And we can't really entice them too much with stipends. So it's more difficult to recruit for patients. But a lot of these are covered. Like I said, the primary reason the group that put together the funding for Liletta did that is because they did want just a cheaper alternative to the Mirena. And the Mirena prices have gone up. They knew that the Liletta was going to be coming out. Like I said, the Liletta currently has a 3-year approval rate, but because of the ACA, a lot of the contraceptive agents are being covered, which is a good thing. I guess the question just is, with the, I guess some exceptions that are out there for employers, I guess that's still being debated in the courts. But the whole goal is to have as many contraceptive choices for all women across the board.
Very good. Another question. Okay, so it's mostly the ladies are making the decisions still. Not
Yep.
much for men.
Not yet.
And
Condoms.
Yep. And,
Condoms, and
there
or
you go.
vasectomy.
Okay. Well, thank you again. We appreciate you being here,
Thank
Dr.
you.
Thomas. Give him another hand.